We are live.
Can we start?
Yes, ma'am.
Okay. Good evening, everyone. Welcome to lecture number 46 of refractive surgery. Today's topic is contact lens use after refractive surgery. It will be presented by Dr. Garvita Dabas. Can we have the next slide, please? Welcoming the moderator for today, Dr. Amita Kaul, ma'am. She has done her MBBS and MS Ophthalmology from Government Medical College, Jammu. She has completed her fellowship from Rajiv Gandhi University of Medical Sciences at Bangalore. Ma'am has specialized in cornea, cataract, and refractive surgery, complemented with comprehensive experience related to the surface disorder LV Foundation. Ma'am has more than 11 years of ophthalmology experience. Currently, ma'am is a consultant at Center for Sight, New Delhi. She has more than 20 peer-reviewed publications and has delivered lectures in national and international conferences. We welcome you, ma'am.
Thank you so much, Shreya. Yeah, I'll be introducing Dr. Pratiksha Sharma, please, if that is okay.
Yes, sure.
It's my honor to be introducing the chairperson for today's session, Dr. Pratiksha Sharma. Ma'am is MBBS from Lady Hardinge Medical College, Delhi, and MS from MAMC, Delhi. She has done her senior residency from GNEC, and she's currently a consultant at Center for Sight, Haryana. She has previously worked as specialist ophthalmology at the ESI Hospital, Haryana, and she has been the recipient of Champions Award at YOSI, and she has a distinction in medical training. And ma'am is a very avid person who takes a interest in training of fellows and postgraduates. She has authored over 30 journal articles and has given over 40 presentations and lectures at various ophthalmic meetings, national as well as international. We welcome you, ma'am. And with this, I would
Thank you,
now
Dr.
like to introduce the speaker, Dr. Garvita. She's MBBS from D.Y. Patil School of Medicine, Navi Mumbai. She is a gold medalist in her MS from Muzaffarnagar Medical College and Hospital. She has a fellowship in cataract and refractive surgery from the Center for Sight, New Delhi. She's a gold medalist in FAICO refractive surgery, and she's currently the associate consultant at the Center for Sight, New Delhi. She's a recipient of various prizes in photography, papers, and poster presentations in many, many conferences. And she has authored over 8 journal articles and delivered 6 instruction courses and over 30 presentations and lectures at various ophthalmic meetings, both national and international. And she's also the co-author of 4+ chapters in ophthalmology books. With this, I hand over the podium to Dr. Garvita.
Thank you, ma'am. Thank you so much for the kind introduction, ma'am. Not to delay it, I would start with my presentation now. Hello, good evening, everyone. Welcome to this session on the use of contact lenses post-refractive surgery. In today's session, we will be dealing in depth with the types of contact lenses available, their contact lens fitting, and their use post-refractive surgery for our patients. So before we dive into the details of contact lenses, I would like to discuss the corneal anatomy for just a minute, just to revise the topic. So as we know, cornea forms the first 1/6 of the outer coat, while the sclera forms the 5/6 of the outer coat, and it is responsible for 2/3 of the eye's overall refractive power. It is a transparent avascular structure that is maintained anteriorly by a layer of tear film, which is the supplier of the oxygen, and posteriorly by the aqueous humor from the anterior chamber. Further, cornea is prolate in shape, which implies that it is flatter in the periphery and steeper centrally, and it creates an aspheric optical system. So the cornea has 5 distinct layers: the corneal epithelium, the Bowman's layer, corneal stroma, descemet, and the endothelium. So the first is the corneal epithelium junction, which is the outermost junction present here. I'll just bring my marker out. Yes. So this is the outer most layer, which forms the air tear interface, and it helps to smooth out the micro irregularities of the corneal surface, followed by Bowman's layer, which separates the epithelium from the stroma, followed by the corneal stroma, which forms the 90% of the corneal thickness and constitutes of collagen fibrils, which are fashioned into lamellae and responsible for the cornea's tensile strength and structure. Ultimately comes the Descemet's layer, which is a strong layer that separates the stroma from the endothelium. Finally, it's the endothelium, which is the innermost layer, and it is imperatively important for the corneal fluid balance. So, what is corneal topography? As we've already discussed it in the previous classes, just to revise it, it is a non-invasive imaging technique that measures the contour of the cornea, and it is very important for our contact lens fitting, because the topographical analysis of this post-operative cornea, it helps us to find the base curve of the contact lens that is to be fitted. Further, the topography of a normal, typical, untouched cornea is prolate, as we've already discussed previously, which implies that it is steeper in the center and flatter in the periphery. These are the four main maps that help us in planning a contact lens. First is the axial or the sagittal map. So this map is based on the para-axial ray theory, and this map has a very good repeatability, and it is considered the most useful and the easiest map to verify for your contact lenses. One drawback is that it may distort the position of the corneal apex and the ablation area position. However, it also mimics the keratometry measurements most closely. Next is the tangential map, which includes extreme curvature values and is better characterizes the irregular astigmatism if it is present. Also, it reflects the apex more accurately, and it is very useful for the optical zone selection in cases of a RGP, which is a rigid gas permeable contact lens, because it is then helpful to target the vaulting of the contact lens over that particular area of the cornea. Further, if we compare it to the axial maps, these are, however, less easy to verify and less repeatable. Therefore, but they will characterize the flat area to be flatter and steep area to be extremely steeper. Coming to the corneal height map, they are based on the height of the cornea as compared to a reference sphere, and they are less repeatable than both the axial and the tangential maps. Finally, the refractive power maps, these are the simplest maps to interpret. They basically detect the curvature of the cornea and coincide with the refractive reading. They are also least useful when it comes to a contact lens fitting post-refractive surgery. So what are the changes that can happen to the cornea topography after LASIK? First are the primary biomechanical changes, followed by myopic changes, followed by hyperopic changes or corneal irregularities that may be introduced post-refractive surgery. First, coming to the biomechanical changes. For example, during LASIK, as we can see in this diagram, this is an untouched normal cornea which are showing the arrangement of lamellae, and this is the anterior surface, this is the posterior surface. So what happens during LASIK is when the LASIK flap is formed, the stromal lamellae are permanently severed. This severance causes reduction of the tension in the peripheral layers, and this reduced tension leads to this peripheral expansion on both the sides, which can increase the curvature of the periphery, and that further causes radial force that pulls down the central cornea. So centrally it comes down, whereas peripherally it actually increases the curvature. This biomechanical flattening effect can occur in both myopic and hyperopic LASIK repairs, because both of the effects cause severance of the lamellae of the stroma, which can cause this biomechanical changes. In particularly talking about myopic, post-surgical cornea of a myopic ablation leads to an oblate topography from a prolate topography. What it means, it's post a myopic correction, the center becomes flatter with a relatively steep periphery. As the degree of correction increases, therefore, the amount of ablation increases, this effect is increased. That is, more the correction, more is the difference between the flat and the steep periphery. Post hypermetropic repairs, the central cornea is made steeper as compared to the periphery. However, in such cases, the functional optical zone are much larger if we compare it to the myopic treatments. But they are also less uniform as compared to the myopic treatments. This variability of the functional optical zone in hypermetropic eyes, that is, it is more concave and has a paracentral ablation. This causes more transition points as compared to a myopic treatment. This problem leads to centration of contact lenses post while fitting contact lenses post hypermetropic repairs. Last point, corneal irregularities. As we all know, higher order aberrations may be induced post refractive surgery, which can lead to decreased night vision, glare, halos, and visual distortions. This can lead to patient disappointment post refractive surgeries. So now coming to contact lenses. The history of contact lenses, the earliest history was when contact lenses were made, particularly the scleral lenses were made out of glass. However, as we can all imagine, it must be very painful and very difficult for fitting these contact lenses. So by the early part of 20th century, these lenses were abandoned and PMMA on glass both were abandoned. However, there was a problem with corneal hypoxia that kept increasing for such people. So the smaller corneal lenses were incorporated and which settled on the ocular surface, and they became more commonly acceptable as a contact lens correction form. However, as we progressed through the 20th century, there was introduction of rigid gas permeable lenses, and there was a more improved tolerance as the quality of these contact lenses improved and the difficulty of corneal hypoxia was tackled. So corneal hypoxia was initially a huge problem because the transmission of oxygen through previous materials like PMMA, glass or standard hydrogels was difficult. However, at present, due to availability of silicon hydrophilic material and even hyperpermeable RGP lenses, they have also been introduced because of increased oxygen transmissibility, and therefore such lenses are also advocated for overnight orthokeratology contact lenses that may be used even during sleep at night, which is while the lid is closed. And nowadays it has better tolerance. Patients develop better tolerance to such lenses for an extended use as well. So coming to contact lens use after refractive surgeries. So what are the indications of contact lenses post-refractive surgery? They can be, for example, post-refractive surgery if may have under or over correction, if we have refractive error shifts, if there are incidents of irregular astigmatism or formation of central islands, if there is corneal haze, or even in multifocal corneas, patients can have several options to address these issues. And if we are looking to before planning a surgery, if we want a temporary option, we can always opt for these contact lenses or spectacles before undergoing a permanent surgery. So the indications are residual ametropia, irregular astigmatism, anisometropia, decentered ablation, and even therapeutic bandage contact lens use, which are routinely used in our practice, especially for patients undergoing photorefractive keratotomy. So What are the types of lenses available at present? Therapeutic bandage contact lens, soft hydrophilic contact lens, toric soft contact lenses, rigid contact lenses, reverse geometric lenses, combination contact lenses. Then there are lenses for corneal ectasia, and finally scleral contact lenses. So all these lenses are available in our armamentarium, and I will be just briefly discussing each and every one of them. So the first is a therapeutic bandage contact lens. And traditionally, as I mentioned, we have used it post photorefractive keratectomy to protect cornea from the inflammatory cells in the post-operative period. They are routinely used for the initial 1-2 days while we are preparing for the cornea to heal and the epidefect to heal post PRK. And even in LASIK, they are used to protect the flap, to prevent fibrotic growth, to prevent epithelial ingrowth, and to provide additional patient comfort. These are at present the best available lenses and they are generally made of silicone hydrogel disposable lenses. The advantages of BCLs are many. For example, they are known to promote regeneration of corneal epithelium and protect it from mechanical shearing of eyelids, especially while the epidefect is healing during the initial days of PRK. Secondly, BCLs are used after PRK and LASIK to more importantly reduce the discomfort, pain, and foreign body sensation for the patient. In post-LASIK surgeries, BCLs reduce discomfort, epithelial ingrowth, and improve healing. BCL are also recommended for treatment of epithelial defects in lenticule surgery such as smile surgery or the silken surgery, and they are also known to reduce inflammation, especially at the incision site. Even after refractive surgeries, BCLs have been known to protect corneal healing and lessen dry eye discomfort. And even if there is an intra-op epidefect present, we can always provide a BCL for the patient to assist in their corneal healing. This is a tabulated chart I found which summarizes the use and the effect of BCL. Firstly, in PRK surgery, generally preferred over the age of 18, BCLs can be kept in situ for 1 to 7 days, and minimum of 3 to 4 days it's generally incorporated. Early phase benefits include post-operative symptom relief, reepithelialization, healing, and late onset. It can have varied effects. Yes, followed by LASIK, which is again BCL wear time is almost 4 to 7 days. Most significant time is 5 days. Early phase benefits again include pain, foreign body sensation, dry eye, tear, epithelial corneal healing. In femtosecond LASIK, we have at least BCL wear time of 1 to 3 days, and significant effects are seen in 3 days, such as reduction in post-operative symptoms. In long-term benefits like 3 to 6 months, we have studies that show improved visual acuity, tear film breakup time is improved, and even Schirmer's test is improved. So the dry eye is easily managed with the BCL. Epithelial LASIK is again for 7 days incorporated. Contact lens are incorporated, and the early phase benefits are in reduction in pain, foreign body sensation, followed by even in smile. PCLs can be worn from 8 to 24 hours, and even within the first 8 hours, there is reduction in pain, improvement in blurred vision, and burning sensation for the patient. For other ocular surgeries like cataract, vitrectomy, and even corneal cross-linking, in cataract studies have found reduction in pain relief even within the first 7 days, improved corneal epithelium. Early phase benefits show OSDI index is improved, tear breakup time is improved. Long-term benefits show reduced inflammation and even reduction in improvement in tear breakup time. Even BCLs can be worn post vitrectomy also. That helps to maintain the epithelial integrity. And early phase benefits show improved corneal healing, improved reduction in ocular irritation, tearing effects, and epithelial defect formation. And ultimately, long-term benefits show epithelium cure, healing well with improved visual acuity. Corneal cross-linking is again where BCL is routinely used, and the BCL may be worn for 3 to 4 days, where the patients are helped with their pain and reepithelialization of the cornea. So there are various complications of BCLs which are linked, especially after refractive surgery, such as infection. Post LASIK, there may be some signs of flap edema, followed by blurring of vision. There may be meibomian gland secretion or debris that can settle underneath the contact lens, and occasionally BCLs may also cause patient discomfort. Coming to soft hydrophilic contact lenses, these are traditional soft lenses that may be worn post LASIK as long as the primary postoperative complaint is anisometropia and they only require small refractive corrections. However, it is important to note that patients with significant refractive errors are not a good candidate for these lenses, for the soft lenses. And advantages are that if the minor refractive error is treated well, with these contact lenses, patients are comfortable, and also these being soft, they offer good centration. And disadvantages are that they don't perform well in large refractive errors, and also they sometimes offer poor visual acuity and difficulty in fitting. So there are various studies that have been conducted post-refractive surgeries with soft contact lenses, and a few studies reveal that almost 10 to 25% patients requiring corrective lenses were able to achieve adequate vision. And also in another study of 29 eyes, almost 26% were successfully fitted with soft hydrophilic lenses. I would just like to mention here that there is a Harrison post-refractive surgery lens, which is a soft lens and approved by the FDA to be specifically used post-refractive surgery. And this lens offers a central flatter optical zone as compared to a mid-periphery. It has a reverse geometry design that allows the lens to drape over the steep parts of cornea. I will be dwelling into reverse geometry design lenses in the next few slides. So finally, coming to toric soft contact lenses, these are ideal for patients again with minor astigmatism, which is around 0.75 DC, and also they're associated with atypical rotation when fit on oblate, that is treated myopic treatment, versus the normal, that is prolate cornea. Therefore, such lenses, as they're more prone to rotation, they may be difficult to fit, and a empiric fitting is not recommended for these lenses. Toric lenses are again specifically not recommended for high degree astigmatism because of instability, and also they are not capable of treating the irregular part of the astigmatism. Finally, coming to the rigid gas permeable lenses, these are the lenses of choice when fitting post LASIK surgery. And there are a number of qualities of these lenses that makes them most used. Number one, they are able to correct high degrees of both regular and irregular astigmatism. They also at present offer good oxygen permeability and therefore good visual acuity correction. They are also well tolerated by patients, and nowadays these lenses are available for extended use as well. So an RGP fitting post LASIK cornea is very difficult when fitted when in alignment with the peripheral cornea, as we see in this diagram, because there is a central flattened region that can cause instability of the contact lens, and as shown by a central pooling in the center, and there may also be trapped bubbles here which can cause poor visual acuity. Therefore, it is important to use pre-operative as well as post-operative topography when fitting these patients with contact lenses. Coming to reverse geometry lenses, The most important quality about these lenses are that there is a secondary curve followed by the base curve, which is a reverse geometry curve. So these are a type of RGP when there are indicated with significant difference between the flat and the steep cornea, because these lenses have a steep secondary curve as pointed by my pointer here, to accommodate this flattened central region and a flat central region to accommodate the tear layer between it, and then further it decreases the myopia. Therefore, these lenses are currently unanimously used with the orthokeratology. So what is orthokeratology? It is an technique wherein a patient wears the reverse geometry lenses overnight such that the cornea is reshaped temporarily, and as you can see in this picture, an orthokeratology lens is placed, and almost after 8 hours of use, the cornea is shaped here temporarily, and a typical bullseye of fluorescein pattern is seen, wherein you can see the central 4 to 5 mm is clear, followed by fluorescein pooling of the next 1 to 2 mm, which is the tear reservoir, and there is a 1 to 2 mm peripheral zone of light touch. Finally, coming to combination lenses, they are indicated when patients are hypersensitive or intolerant to RGP lenses, or they experience a strong foreign body reaction and a lid sensation. Soft lenses would be ideal solution to these patients. However, soft lenses cannot give you an ideal visual outcome, which is why combination lenses are preferred. And in these cases, a piggyback lens, that is an RGP lens, is fitted on top of a soft lens that can be used. As I mentioned, silicone hydrogels are the soft lens of choice, and they are combined with the RGP lenses. And silicone hydrogels, they actually provide a good oxygen permeability as compared to the conventional soft lenses. So as shown in this picture, a combination lens can also come as a hybrid lens, wherein there is a central uh, gas permeable contact lens surrounded by a soft lens skirt. So Synergize is one of the brands that are available that offer such lenses, and they have a rigid center that can help the patient with the visual acuity, and whereas they have a comfortable skirt around it that offers comfort and good oxygen permeability for the patient. It also has incorporated a UV blocker. So post hypermetropic repairs and post iatrogenic corneal ectasia. So these are two identities where we require wherein the cornea tends to bulge out. That is, the in post hypermetropic, the central cornea is steep than the periphery, and in iatrogenic corneal ectasia, the peripheral or the cornea, the weakened cornea bulges out. And contact lenses are indicated in both of these cases for almost mild to moderate cases. And the lenses of choice are generally RGP lenses, as they mold the cornea to provide a good visual acuity. And there are also some specifically designed multi-curve lenses. The examples are either rose scale lenses and the Woodward design lenses. I would just like to highlight the rose scale lens here, as it is a widely used contact lens, especially for in cases of keratoconus and iatrogenic corneal ectasia. They are very successful for those patients where the cone apex is central. However, if the cone apex is not central, they do not perform very well. And the rose scale lens incorporates a flat and steep peripheral system and an ideal edge lift of 0.8 mm, and they're available in various base curves and diameters. A large diameter is generally preferred for moderate cases, and even toric varieties are available. Finally, coming to scleral lenses, these are a type of RGP lenses. However, they are treated as the lens of last resort. So as the name suggests, scleral lenses. they are supported entirely by the sclera, which allows the lens to overcome the surface abnormalities of the cornea as depicted in the picture below. As we see, the scleral lens rests upon the sclera and it vaults over the entire cornea. And if we see the corneal irregularity here, there is a liquid reservoir which is formed by the tear film inside that offers a smooth interface. This makes them a very good option for large corneal abnormalities and moderate to severe post-refractive ectasias. They may also provide an advantage of improving dry eye symptoms post-refractive surgeries. Another use of contact lenses is post-RK surgery. RK surgery are not done anymore, incisional surgeries. However, contact lenses may be used for visual rehabilitation post-RK surgeries. So, post-RK, there are a few fitting challenges for contact lenses. For example, the topography may seem there is a vast difference between the central and mid-peripheral corneal topography. There is also anisometropia, anisoconia. There may be irregular astigmatism. There may be elevation of incisional scars along with corneal neovascularization in those scars. Also, as we all know, RK offers a diurnal variation of vision, that is, the refractive error fluctuates between day and night. And there is also post-operative glare and photophobia. So these are certain challenges when it comes to contact lens fitting. So when do you fit a contact lens following RK if a patient comes to you? So ideally, it should be when the incisions have completely healed and the epithelium is regularized, and once the corneal topography and refraction is stable. So once you have stable topography and refraction, only then you can take into account the topography and plan a contact lens fitting. There are different types of lenses available. There are RGP lenses, mini scleral lenses, reverse geometry lenses, and hybrid lenses available. So coming to contact lens fitting, what happens in a contact lens fitting? So firstly, a patient's vision testing is done. That is, glass prescription, topography, contact lens prescription are all taken into account. The cornea is measured. That is, topography is accounted for, and also the eye health, as it the dry eye symptoms, the allergies in the eye, all these multiple aspects are taken into account to offer the best possible solution to the patient. It is important to counsel the patient throughout the procedure, discussing the type of contact lenses available. For this, the patient's work profile is very important. Is the patient into contact sports? Does the patient want to wear contacts regularly? Does the patient want to occasionally wear contact lenses? Is the patient comfortable? Because it is very difficult for the patient to suddenly adapt into contact lenses, especially when the patient is not motivated. Second important factor is every patient that comes for a contact lens fitting requires a thorough counseling for how to maintain contact lenses. For example, how to use contact lens, how to keep and store contact lenses, tips on avoiding water, tap water, tips on avoiding rubbing your eyes, and in cases what are and counseling the patient what chances are higher risks of what the contact lens disposes the patient to. For example, higher risk of infection, higher risk of corneal abrasion, if these measurements are not kept into mind. Finally, it is important for the optometrist or the contact lens specialist and the eye doctor to work as a team and find the right fit for the patient with the right design of the contact lens. Only then the patient will be comfortable. So how to approach for fitting of a contact lens? Number one, post-refractive surgery, give time to the cornea to heal. That is, we ideally go for 8 to 12 weeks of stabilization, and only then, once the refraction and topography has stabilized, only then after we plan a contact lens fitting in case the patient is eligible for it. And fitting in a post-refractive patient is more difficult than non-surgical or untouched, unaltered eyes. The reason for that is post-refractive surgeries, patients might already be slightly disappointed with their outcome. They may not be well receptive to other treatment options, and some patients may feel that they have undergone refractive surgery to remove their refractive power, and ultimately they have to wear contact lenses. So, a thorough chair time and evaluation is very important for such patients, and it is very important to motivate these patients so that they may use contact lenses for a extended period of time. And ultimately, as we all know, post refractive surgery, the patient may also complain of dry eye. Patient may also have increased foreign body sensation. And so, therefore, such lenses should be selected for the patient that the patient is comfortable with. For example, lenses with moderate to high oxygen transmissibility, and to ensure the cornea has adequate oxygen supply. The Steele and Davidson review, it's a wonderful review that they have done for using of contact lenses after refractive surgery, and they have in detail dealt with most of the aspects of using contact lens post refractive surgery. I have in brief discussed here about the review. So they have suggested that if the patient can achieve good vision with spectacle correction, then the first choice of contact lens should be a soft contact lens. And within the soft contact lens, the primary preference should be spherical, aspheric, and toric designs. However, if the patient had a significant amount of tissue ablation, for example, patient who had a high refractive error, patient who has a high residual amount of refractive error, for such patients, an RGP lens is the best fit with either pre-op or post-op topography information. Thirdly, if a large amount of tissue has been ablated, that means if the contact lens that we prefer, the diameter should be large, or a reverse geometric contact lens might be a better option because of the larger optical zone. Finally, patients who received hypermetropic LASIK or whose post-operative course is complicated because of ectasia, therefore, they should be fit for lenses which are designed for keratoconus, for example, the rose scale lenses. And finally, scleral lenses should always be considered as a last resort. So, as this diagram shows, this is a contact lens incorporated in a patient of keratoconus, and however it was used for a hypermetropic correction, post hypermetropic correction of almost +6. So patients here perform much better with such contact lenses. Coming to RGP lens fitting, most studies recommend starting the treatment of contact lenses post-refractive surgery as the RGP lenses. And the initial diagnostic lens selection should be selected based on, as I said, pre-operative or post-operative topography. If topography is not available, only then the empirical selected lenses may be used. And almost 70 to 80% of patients who require contact lenses for visual correction after LASIK end up receiving a specialty contact lens, which is almost always an RGP lens. And in such patients, first a lens trial is recommended rather than dispensing the lenses directly. The idea is that the lens bearing should be present in the mid periphery along the horizontal media, which is almost 3 to 4 mm of the center of the cornea. The back optic zone radii, which is the BOZR zone, should be 0.1 mm steeper than the mean keratometry reading, and almost the diameter should be large, which is 9.2 to 10 mm in diameter. And the fit is then assessed by the fluorescein staining. For example, you can either look for the bullseye pattern or you can see the 3-touch technique. as the patient blinks, there should be a good movement between 0.5 to 1.5 mm. It should cover the pupil adequately, and there should be a good tear exchange that should be present. If fitting a reverse geometry lens, as I mentioned, there should be a slight central clearance followed by a good central fixation and a mid-peripheral alignment. So coming in detail to the reverse geometry fitting, as we see in the diagram, typically the secondary reverse, which is the second curve here, it should be 1 to 5 diopters steeper than the BOZR zone. The optic zone may range between 6 to 8 mm, and the diameter should be large from 9.5 to 11.5 mm, because to aid the stability of the cornea, the contact lens over the cornea. And when fitting a reverse geometry lens, the fit should have a central clearance as shown here, a good centration and a mid-peripheral alignment. So this is an example of a picture with the Paragon CRT reverse geometry lens, and these are the specifications of the lens the patient was fitted with. It has been taken from the Steel review. Coming to soft contact lens fitting. So the soft contact lenses are a good choice with pure anisometropic errors for most importantly, small refractive errors and patients who cannot tolerate an RGP lenses. The first lens choice should have a BOZR zone that is 0.3 mm flatter than the flattest keratometry, and the lens should have adequate centration and movement on blinking, which as I mentioned is 0.5 to 1.5 mm, and there should be a complete absence of central bubbles. There is a variability in rigidity among soft contact lenses brands. So that means if one contact lens does not fit the patient, that does not mean all contact lenses may fail. You have to try different brands and different materials of soft lenses, provided they are all hydrophilic lenses. One important point I want to highlight here, this is a bubble trapping of the of the air bubble trapped under the contact lens, which is also called fluting of the contact lens. So there is an elastic modulus of a contact lens that measures the stiffness of the contact lens. The stiffer the contact lens, the higher will be the modulus, and therefore it is greater resistance to the deformation. This is particularly important when the lens has a low modulus. That means it is more stiff, and whereas if a patient lens has a high elastic modulus, it is more stiff. So in such cases, if we avoid the lens fluting here, as you can see in this picture, there should be the lenses should have a low elastic modulus. Finally, the combination lens fitting. The best approach is to fit the hydrogel contact lens with low plus back vortex power and then measure keratometry with the lens in place. And the BOZR zone should be between 7.8 to 8 mm, and the RGP lens should center well over the soft lens. Coming to complications of contact lens use after refractive surgery. As shown in this picture, the lenses should not impinge upon the conjunctival vessels and they should not disrupt the blood flow. So there are various complications of contact lenses after refractive surgeries. The complications include wearing bandage contact lenses that can lead to corneal edema, infection, increased risk for corneal striae also. Lenses that do not allow oxygen diffusion can lead to compromised integrity of corneal stroma, followed by corneal myomechanical parameters may change after contact lens wear post LASIK. Also, the corneal resistance factor can change significantly, seen in some studies after 1 year of contact use post LASIK. Also, there is central corneal thickening, corneal hysteresis, and cornea compromised intraocular pressure that can show significant changes. So to summarize, contact lenses after LASIK are occasionally necessary when there is residual ametropia, irregular astigmatism, anisometropia, and decentered ablation zones. And corneal topography changes after surgery can make contact lens fitting challenging and labor intensive. However, when such patients are properly fitted for contact lenses, they may just be extremely thankful, and it's almost a miracle for them. So it's definitely labor intensive, but a good work can help with good outcomes. There are also a number of different lenses available, so all the options should be given to the patient. And also, the with appropriate fitting techniques, post LASIK patients who need further vision correction should be able to successfully wear contact lenses. Thank you.
Thank you, Garvita.
Thank you,
That was a
Dr. Garvita.
really, it was a really illuminating presentation. So I have a couple of questions. First, I'll start with you, Garvita. So if you're prescribing a soft contact lens to a patient for the first time, say post-refractive surgery, if they have a low error, like you were talking about the Steele and Davidson review, and they have said that if it's a lower error, we would like to use soft contact lenses, or even if it is a new patient coming in, they want contact lenses for the first time. So, what kind of workup or what kind of counseling would you like to give to the patient? Like you mentioned in one slide, all the things that we're supposed to do before we give contact lenses to the patient. But I think that was more in context to RGP lenses or the specialty lenses that we were talking about. But what would be the general counseling that you would give to the patient on how, what kind of workup would you want to do for the patient before you prescribe them lenses?
Ma'am, if a general patient who's not been planned for any refractive surgery walks in the OPD, basically I would like to first assess the requirement of contact lenses. For example, there are some patients who want to wear contact lenses occasionally. They may be color coded contact lenses, or they may be for their anisometropia or a refractive error. There are patients who come for contact lenses during their if they are playing in active sports or in contact sports. So depending on their profile, I would like to guide them regarding their choices. I would like to also thoroughly evaluate how motivated the patient is primarily, because if a patient is not well motivated, the patient wearing contact lenses is a lot of hard work, and maintaining those contact lenses is also very
Even more
important.
hard work.
Yes. So if the patient is well motivated, I want to first inform the patients regarding the pros and cons of it. The important part is, yes, it gives you a liberty from glasses, but it also brings along with it a lot of complications like foreign body sensation, long term contact lens red eye, or recurrent corneal erosions. Patients are not supposed to rub their eyes, no use of tap water. They're only supposed to use the contact lens solution given to them. So a lot of hygiene talk, a lot of you're not supposed to sleep wearing contact lenses. All these general pointers are first given to the patient. And if after all this discussion, even patient is still motivated for contact lenses, only then I tell them to get a contact lens fitting done. And once they are satisfied with the contact lens trial, they can perhaps use contact lenses on a more regular basis.
Right. So I would pose the same question to Dr. Pratiksha also. So do you like to do any topography before, like there's a 17-year-old kid, they have a moderately high myopia and they want to use contact lenses because obviously nowadays kids are more cosmetically conscious. Nobody wants to wear thick glasses. So I had a patient like that, and I was wondering if there was a way to better counsel or do some workups before. So do you do any workups before you do a topography routinely, Dr. Pratiksha, or how do you go about it? Or is it just general counseling and you just prescribe, or do you do the dry eye evaluation once for the patient, like check the baseline Shermers, or do you give them a trial of contact lenses in your clinic first? How do you go about it?
Yeah, routinely, Dr. Amita, routinely for every patient, we don't go for topography. Looking at the refractive error itself, we can somehow judge clinically whether the patient has some type of corneal problem or not. In certain cases only where, as she mentioned, that maybe high cylinders or maybe some irregular corneas, where I would like to go for topography. And then, as Garvita said, I would like to add few more points. Like nowadays, mainly the people who are going for contact lenses are the younger generations, and these younger generations, they sit on laptops for like 9 hours, 12 hours shift. So it is, and they are already suffering from the dry eye. So it has to be very, very cautious about that. Like you cannot use it for such prolonged period, and then already you are suffering from dry eye, and it will aggravate the conditions. And then also, before going for investigations, I would like to do a proper examination of the eye, including the eversion of the lids, looking for follicles and any scarring, any history of such diseases. Like it is very, very, especially the superior panels. We usually miss all these in our OPDs and contact lens liner, and then we just prescribe. So I think these things are really very important, especially for the population, those who want to go for the contact lenses. um, I have not like much faced kids coming for this condition, because when the parents are involved, they usually don't prefer contact lenses. They usually go for spectacles, and then they have ever-changing refraction, all those cases. So I don't go for topography in every case. Like wherever I feel like that it has to be done. But more important is the local examination of the eye, that is detail examination, and then history
So
taking.
slit lamp biomicroscopy, basically, history taking thoroughly,
Yeah,
and then one clinical examination will give us a lot of clues about what we want to do, right? So do you have any experience with hybrid contact lenses?
not much.
Okay. What about you,
Not.
Dr. Garvita? Any first-hand experience with using hybrid contact lenses? And if any of you can say a few words about if they can be good in post-cross-linked stable keratoconus. Like I have these couple of patients who have been coming to me not happy with RGP lens. One eye is quite okay. Other eye was cross-linked some time back and is now stable, late 30s, early 40-ish, and are not comfortable using glasses but want to use a contact lens. So, what do you think hybrid contact lens is something that we can try in these patients?
Yes, ma'am. I feel hybrid contact lenses offer good comfort at present because of the soft skirts that is there. And at least in Safdarjung centers, we have the dispensing the hybrid contact lenses for
Hybrid.
some of our patients. Even the miniscleral contact lenses in such cases are performing better than scleral or pure RGP lenses. So, yes, there are these options available where we can tell the patient that specifically post CXL patients, these patients need to have a contact lens trial and they need to be ascertained with they don't have blind promises that everything will be okay, but they need to have realistic expectations where a trial can help them. There are some patients who have undergone for the trial very motivated that we'll get it, but post trial they're not happy that
Happy.
yes, it's not extremely comfortable. Also, ultimately there is a contact lens in the eye, but again it varies from patient to patient. Some are very happy, some are not. So whoever are happy, whoever can be helped with a mini scleral or a hybrid contact lens, so I feel it should be an option that has been offered to the patients.
And what about the routine RGP fitting? Like for RGP fittings, do we go for using tangential maps for all the patients, or do we just use a power map, a refractive power map?
Ma'am, refractive power map is definitely done, but yes, tangential maps that offer us the idea, thus, especially post orthokeratology kind of reverse geometry lenses. These lenses, when incorporated, as they have a reverse curve secondary to the base curve, so there the post orthokeratology contact lens cornea is definitely highlighted better in a tangential map as compared to a simple axial map. So it is important, but everything has its own particular use in different situations.
So, Dr. Pratiksha, any experience firsthand dealing with orthokeratology lenses? Have you ever used, because childhood myopia is a very real problem for all of us. We who are cornea specialists, but see a lot of pediatric cases wherein patients are having high K values, high myopia, and progressing, and nothing seems to be working. I mean, a lot of defocus lenses are being used, and a lot of atropine low dose is being used. But do you think orthokeratology is something we should try? Because in West, I believe I have a few colleagues in US who are practicing ophthalmologists, and there they usually do practice orthokeratology, and they claim to have very good results. However, in India, wherever I have worked, I have not seen it being used much. So I was wondering if you have any personal first-hand experience of using orthokeratology or seeing patients who have undergone this and they have any significant benefits. Hello, Dr. Pratiksha, am I audible?
Yeah. Sorry, I got dropped. Yeah, I think it's an emerging branch. We'll come to it soon. Initially, we have to actually start with the aphakic infants. Like we are not even, we live in such a country where the conditions are not suitable even to use contact lenses in aphakic less than 2 years kids. So we will have to start with that, and slowly, I think this keratology will become part of our practice also. But I think living in such a country, we are slowly developing for that. As such, I don't have much experience with that because still we are dependent on the glasses, and there is newer technologies like myocare and then atropine and all these things. So practically, I don't have any experience, but I feel soon we
Right.
will have.
Right.
Yeah,
So,
also
Garvita,
Garvita,
have you? Yeah, ma'am, please carry on.
yeah, so I wanted to add, Garvita, you have given a beautiful presentation, but in all the conditions which we discussed here, whether it is post-refractive or it is like irregular corneas or ectasias, these I feel these corneas are already like compromised in relation to the tear film.
Yes.
So assessing that and keeping that in mind, along with the usage of contact lenses, again very very important.
Very
Well,
important.
it seems to be a dry eye, seems to be a very small thing, but if you look at the OPD, I think 90% of the OPD is suffering from dry eye, whether it is post LASIK, post cataract, in fact post pterygium also the
Yes.
irregularities cause dry eye. So that is again very important part, and like most of them are putting drops, still unsatisfied, those foreign body sensitive.
I think we lost Dr. Pratiksha.
Yes, ma'am.
Yeah. So yeah, so that is what. So what she is saying is a very valid point that we need to first see the ocular surface as a whole.
Yes.
It's always imperative to do. Yeah, Dr. Pratiksha, she's back. Yeah, that's what we were just. So we lost you in between. So that's what I was saying. That it's very important to see the ocular surface as a whole and look at the tear film, which is very important. We often forget that tear film is actually the first lens with which the light strikes before it strikes the cornea and gets refracted. So sometimes things like inadequate or not a very good or a healthy tear film, these things can also cause problems. And with contact lens fitting, especially because the kind of tension that the tear film provides, that causes the contact lens to actually stick with the eye. So I have seen a lot of dry eye patients suffer endlessly by using they keep trying to put the contact lens inside the eye, but there is no tear film, there is no surface tension over there. So the stick on of the contact lens is very difficult, and then they keep using their screens for prolonged periods of time, and there is no visual hygiene. Nobody has ever explained to them the lifestyle modification that is needed, is imperative to be done when you're using screen for such prolonged periods. So I guess you're very right when Dr. Pratiksha said that looking at the tear film, and we are of course a developing country, so there is more thrust on probably working clinically than on doing the counseling part or the due diligence part, which I think, yeah, we need to start at the basics and start looking into those things. That would be a great idea. So yeah, on that note, I think when we talk about the ocular surface and all, the PROS system comes to mind, the prosthetic replacement of the ocular surface, which is something we use in chronic SJS or OCP. And the patient is very uncomfortable. They have extreme dry eyes, inflamed eyes, and nothing seems to work. And then we have to use the PROS lenses, and that's the only thing that can give them visual as well as symptomatic relief. Yeah, so it does make a lot of sense, seeing the whole surface as a part of the cornea and the refractive. Uh, yeah, thank you so
And
much. It was a great presentation. Do we have any other questions, Shreya? Are there any questions
Yes,
in the
ma'am. There is a
chat
question on the yeah. There is a question on the group asked by Dr. Nikita. She's asking what kind of contact lenses are used after post-rab bleb leak.
post-trap bleb leak? Okay, would
Yeah.
Dr. Pratiksha like to take that?
I don't have much experience, but I have seen people using simple BCL only for that
Contact
also because
lenses,
it
soft
almost
contact
covers
lenses,
that
Yes.
area. But
right?
I don't have much experience in that.
I think
Garvita,
ma'am,
anything you would
usually
like
it's
to add?
the
Yeah,
Ma'am,
Shreya,
same as what Pratiksha ma'am said, large diameter contact
yeah,
lenses are
contact
the
lenses,
eighteen
important
yeah,
so
millimeter
that they
ones. Yeah.
cover the area of leak
bleb,
and
yeah,
assist in healing so that leak does not increase further. But I feel even soft contact lenses and, as ma'am said, BCL contact lenses should perform very well.
right. Shreya, anything else? Do we have any other questions in the chat box?
No, ma'am, we do not. That was the only
Okay,
question.
great. It is a wrap then. Thank you so
Yeah.
much, Dr. Pratiksha. Thank you, Garvita. It was
Thank you.
an illuminating presentation. Thank you, Shreya, for being here. Thank you so much.
Thank you
Thanks
so
to
much,
the
ma'am.
admin. So kind of you. Thank you, Nikita. Thanks for the question. Thank you so much, Dr.
Thank you.
Pratiksha. Have a great evening.
Thank you, ma'am.
Yeah.
Thank you,
Good
Dr.
evening,
Nita.
ma'am.
Bye, Garvita.
Bye, ma'am.
Bye-bye.
Bye,
Thanks, ma'am.
Shreya.
Bye
Bye-bye.
bye, ma'am.